Hello, today on The Cutting Edge, Dr. Garth Fisher, we welcome one of the most respected pioneer voices in modern reproductive medicine. He is a physician whose work has helped thousands of families experience the profound joy of parenthood. Dr. Mark Surrey is not only one of the nation's top fertility specialists, he is a recognized authority in IVF, reproductive surgery, and cutting-edge fertility science. As the co-founder and medical director of the Southern California Reproductive Center in Beverly Hills, his leadership and innovation have placed him at the forefront of reproductive technology for more than 3 decades. His work touches the most intimate corners of human life, hope, legacy, and family. And behind every success story lies a blend of scientific mastery, surgical precision, and the deep compassion for the emotional journey that couples face. He has been paid to travel to many countries to help powerful people with this hope. Today, we explore the breakthroughs, the challenges, and the ethical complexities and the deep human stories behind modern fertility treatment. Please welcome to The Cutting Edge, Dr. Mark Surrey.
Thank you very much. So this is a pleasure to be here with you, and I've known you for many years professionally, to be probably the most recognized top cosmetic surgeon in certainly this area, if not this part of the world. So it's great to see you again, and we're happy to chat with you about the subject.
That's great. I want to learn more from this. Going to ask you a lot of questions the listeners can learn from, but me also. And I know of your reputation; it's always been a spectacular, number one. And I think they pay you to go to China. I mean, you go everywhere. I mean, you wouldn't think China needs any help, but I guess you help them too.
It's interesting, Garth. Is that okay if I?
Yeah,
use
absolutely.
Your first name?
Absolutely, Mark.
Okay. So there are in many countries very restrictive reproductive laws that control the way in which they live. And sometimes, even though you would think that there are no population problems in some places, such as China, their restrictions make it such that a lot of people from there need to travel to places like the United States, for example, to achieve what they'd like to achieve in regard to families. For example, there are some countries where technologies such as we perhaps will touch upon today, called in vitro fertilization, is not something that is accessible to people unless they're married. It's not accessible to people who are same-gender couples, for example. So there are lots of different reasons why people sometimes need to travel.
Wow. I didn't know that. So that's a great thing to know. Before we even start, I'll have to tell you I have one bone to pick with Dr. Surrey. He's so effective and so great. I was at a party one time, and I think I was 5 feet from him, and I started getting pregnant. My stomach is out now. I feel like I'm about 6 months, and that never went away because I don't know what you did.
It's my fault.
Yeah. Sorry. Mark, what first inspired you to pursue reproductive medicine, and when did you realize that helping families build their futures would become your life's work?
It's an interesting question. It's got a long answer to it, but to make it short, I was interested in surgical procedures when I was in my training, and I got into oncology and cancer surgery, and I liked the technical aspect of it a lot, but I had a real problem dealing with the issues and the repercussions of sick people who sometimes would pass away regardless of how effective the surgical procedures that we did were. So it was very frustrating and actually somewhat personally depressing. Yeah. So around that time, there was new technologies coming to the forefront. And I did a fellowship in England, in London and Cambridge, where the technologies involving in vitro fertilization initiated. And I was able to observe some of these things at their inception, so to speak. And they have really changed dramatically over the past few decades, both in regard to their effectiveness as well as their availability to the average couple. And so it's been a field that I was drawn to initially because I saw a tremendous potential and change in it that will affect many of our lives. And it's been exceedingly rewarding to be able to go places and have little kids come up to me with their parents and realize that had it not been for these technologies, they might not be here. So
Right.
it's been a real terrific profession that has been exceedingly rewarding.
Yeah, I can imagine coming full circle that it's so gratifying to, what you worked, what you did, things that you and the mother and father worked through, and you see the children that's the byproduct of that.
Right.
So, okay, and then how has your perspective on fertility treatments evolved over your decades in practice?
They've changed dramatically, as have the technologies involved with them, Garth, in so much as that initially the focus on a lot of reproductive technologies was a surgical focus involving pelvic reconstruction of fallopian tubes, endometriosis surgeries, which I found rewarding and interesting. The problem with them is that the net result in regard to fertility wasn't as rewarding as we would have liked, and this has been surpassed by the results of things like in vitro fertilization, which essentially bypasses a lot of the surgical processes in so much as that it's possible for couples, for example, to conceive with this technology despite having problems with adhesions, endometriosis, things of that nature. And the technologies have actually begotten a whole new area of reproductive procedures that involve preservation of reproductive abilities, so that people can now preserve gametes such as eggs and sperm or embryos that have been tested to be normal for many years. So we know that as human beings, our fertility declines significantly with time. And, in our society, we find that the peak physiologic reproductive ages, which are very young, 18, 19, 20, is not the time when most of us choose to have families.
Right.
We choose to do so perhaps 20 years later.
Right.
And when we're in our 40s, for example, our abilities to conceive is a fraction of what it used to be. So it's possible, for example, for couples in their 20s to preserve their fertility for 10, 20 years, so that when they are socially, economically, perhaps ready to have a family, they're able to do so. And the technologies involved with preservation of fertility include something called vitrification, which is the way that we preserve human tissue. It's almost like a flash freeze, so that you bypass the process of crystal formation and things that you associate with freezing procedures.
Is this called cryo?
It is, but it's done by vitrification, which is sort of a flash freeze, if you will. It's a very, very rapid process, but it's much more effective than the old methodologies that required the preservation and freezing of a lot of water. And as you know, water forms crystals, and
That's the problem.
that can be counterproductive to viable tissue preservation. So this process of vitrification is the way in which most human tissue is preserved now, and it particularly applies to, for example, eggs. Eggs are the cell in the human body that has more water than almost any other cell. And as such, it is very fragile. And so these abilities that we now have to preserve eggs that are unfertilized is socially very effective for women who are, for example, professional women who perhaps are in their 30s and not interested in conceiving for another few years. But if they wait physiologically until they're in their 40s, many of them are not able to do so. So the abilities that we have to preserve fertility for the future are really very transformative socially
Yeah, I
for
bet.
our society. So it's something that is now become recognized to the effect that a lot of the technology companies pay for fertility preservation in their insurance plans for their female employees.
Oh, that's great.
Yeah.
So what's the recovery rate on, let's say you have 100 eggs and you do the vitrification and, 5 years, 10 years later you come back. How many of those eggs survive the process? What's the percentage?
91.5.
That is fantastic.
So
How can this
more
be
or less.
used? This is really a different part of the thing, but
Sure.
when I was listening to you, some people want to be frozen when they're dying and unfrozen. How this is more complicated, obviously, because the cells are mature. It's not 3 of them. So is this being used in that too, or do you know?
I'm not sure, Garth, about the technologies of vitrification utilized for humans
Yeah.
that are grown. I know that it works very well for eggs and embryos. Embryos that are vitrified are probably 100 to 150 cells that take approximately 5 to 7 days to create from the time of fertilization,
Right.
starting with 2 cells.
Right.
And we now have the abilities to look at what we call morphokinetic analysis of embryo formation, whereby incubation systems that we now have where embryos grow are closed systems. So we traditionally used to think about incubators as these big refrigerators that you would open up the door to take out a petri dish,
Right.
look at it under the microscope and say, aha, here's what we have.
Right.
That's kind of archaic now.
Right. Right.
And we put the embryos into a closed system incubation where there are cameras underneath the incubator that take videos of the cell divisions. So we can actually.
First family portraits.
Yeah.
Yeah.
So we can identify abnormal cell divisions. And a side effect of that technology is that we get better embryo formation than we used to, perhaps because we leave them alone.
Yeah. IVF success rates, and I want you to explain IVF. They've dramatically improved since the 90s, as you said. What scientific advancements have had the greatest impacts in that regard?
Well, there are a number of different things, Garth, that have affected our abilities to clinically utilize IVF. The first one has to do with the ease with which we can obtain human eggs. We used to need to do surgical procedures called laparoscopies to aspirate the eggs from the ovaries. Now we're able to do that by ultrasound without general anesthesia, and it's something that can be accomplished in 15 minutes on average. So firstly, it's very available to people. Secondly, it's very effective because we're able now to inject individual normal sperm into each individual normal egg. That's something called ICSI, or intracytoplasmic sperm injection. We were talking a little bit, Garth, about the evolution of IVF, and firstly, how it's become much more available to people. And what's interesting as well is that it's become more socially recognized and acceptable. 20 years ago, if you use the acronym IVF, most people wouldn't know what you're talking about. Now, most people do
Yes,
know what
of
you're
course.
talking about. So it's something that's sort of out there in our society. People are aware of it. So much so that some insurance companies cover it, some governments pay for it. There are countries in this world where they're smaller countries, Denmark and Israel, for example, that approximately 1 out of 20 people that exist in that country are as a result of IVF.
Oh, that's wonderful.
So it's really something that's been socially and clinically utilized as its effectiveness has increased. Its effectiveness has increased largely because of advances in the laboratory, in so much as that we mentioned the closed system of incubation, where we are able to observe and form embryos in a very effective way. And actually, now we're also able to take some of the cells away from the outside of the embryo, that's called trophectoderm, and identify genetic characteristics with those cells. Initially, it was limited to chromosomal analyses. We can examine all of the chromosomes in the human body from an embryo, trophectoderm.
So you just take one out to experiment or to understand that before
No, you take each embryo as a separate entity, actually. So you take a few cells from the outside of the embryo and test them for their genetics. And routinely, we do chromosomal analyses, but there are also over 600 single gene disorders that you can now test for. For example, somebody can have normal chromosomes, but if both of the parents have something like cystic fibrosis, which is not uncommon, their child would have a significant chance of having that disease, which is a crippling,
Important to know.
problematic
Yeah.
disease. And you can know about that and eliminate the risk of that with this technology.
eliminate the risk by not getting pregnant, or
By eliminating those embryos.
oh, I see what you're saying.
In other
Okay.
words, if the couple is given fertility medications to improve the number of embryos that are produced, which is common and usual, some of them are going to be affected and some of them are not. So you simply don't use the ones that
Fabulous.
are affected. So that's the simple way to do it. In the future, what we're looking at is technologies that will allow us to actually change certain single gene disorders. So this is something that you can
Exciting.
stay tuned for.
It's
Yeah.
exciting. What's the biggest misconception about IVF, in your opinion?
Well, that's an interesting pun. A misconception about conception is that it's, first of all, invasive. It's not invasive at all. Compared to doing nothing, I suppose anything is invasive, but doing nothing is natural human reproduction, which, interestingly enough, is not very efficient. In other words, if you look at fertility statistics, for example, for a couple who is 40, on a monthly basis, they will conceive less than 10% of the time, half of which would be either miscarriages or abnormal pregnancies. So when you look at that same couple with a normal embryo, in our lab, their chances of a conception are more than 70%. So it's significantly different.
That's great. How do you assess which treatment path to follow? I'll try to get them all right. IVF, IUI, surgery, or others? Which one is best for a particular patient? How do you decide that?
It's a good question, Garth. We actually have been limiting to surgical approaches to either people with larger anomalies. So, for example, there's a common problem called endometriosis, that by definition is where the cells that line the inside of the uterus and are extruded with the menstruation grow outside the uterus, commonly in the ovaries, and they can form tumors called endometriomas. We used to surgically remove all of them. Now we find that if they're less than a certain diameter, which is about 3 centimeters or so, they can be treated medically and with in vitro fertilization. And we limit surgeries to those tumors that are more than 4 centimeters in diameter, or larger tumors. So
Right.
that's changed a lot over the years. IUI is, interestingly enough, something a lot of people ask for.
What's that stand for?
Stands for intrauterine insemination,
Okay.
where you place a washed specimen of sperm through the cervix into the uterus. But that's natural conception, meaning that the egg has to meet the sperm in the fallopian tube, has to fertilize, create an embryo that's normal that implants. So there are very few actual indications for IUI medically, and they're reserved for women who have a what's called stenosis, or
Cervical
closure
stenosis.
of the cervix, or the man has a normal sperm count but diminished motility. It doesn't move.
Got it.
So you can wash it and make it move better, but it still has to fertilize the egg and create an embryo naturally. So the statistical advantages of IUI are very slim, actually. So the main indication is people want to do something and they don't want to do IVF. They're not ready to do that.
Right.
So they want to do IUI or something because they
Right.
feel like they're doing something
Yeah.
for a short time, which is okay. The problem, frankly, is that, as we know, human fertility declines as we age. So if you're going to spend a year doing IUIs,
You're running out of.
probably not a good idea. For a month or two, it's okay.
Can you walk us through what actually happens in the IVF lab, the part that patients don't really see?
Patients actually, Garth, don't see much of anything in the lab because it's a closed space. It has its own circulation system, its own air filtration system, its own water system, and it's a pretty tight place that we don't actually go into either. We have locks on all the doors. We change the combinations every
Safe
few
at the
days.
bank. Yeah.
Because we used to have a doctor who was an andrologist. That's a urologist who would aspirate sperm, and he liked to wear cowboy boots, and he would walk into the lab with those cowboy boots on, with mud on those cowboy
God.
boots, and so we keep the lab a pretty closed environment now, and so we don't let people go into it. Even doctors are prevented from going in. So it's kind of a safe place. What happens there, firstly, is that they get some fluid from the ovaries. The ovaries contain follicles, which contain eggs. Within that fluid, they identify the eggs. They look for their normalcy, their maturity, and to see if they're ready to be fertilized. The fertilization process is next. If the patient is wanting their eggs fertilized, as I mentioned, a lot of people utilize this technology to preserve fertility for the future. And for example, perhaps a 38-year-old attorney doesn't have a partner. She just wants to be able to conceive later in life. So her eggs are not fertilized. They're preserved in an unfertilized state, which requires a certain preparation, much different than the preparation for fertilization. So in people who are trying to actively conceive, the next step is the fertilization, which is commonly now done by a specific process called ICSI, or intracytoplasmic sperm injection, where you identify one normal sperm for each normal egg, inject it into the egg, and you're able to then observe the evolution of the embryo to make sure that it's normal. If the embryo is structurally normal, the cells from outside, not inside, but outside the embryo, are taken and sent for genetic analysis, chromosomal analysis, occasionally single gene disorder analysis, and that can take up to a week or so to have us identify which of the embryos are normal and can cause a normal pregnancy. So that's the essence of what goes on in the lab.
It's so great. You're such an expert, just so knowledgeable about all this stuff.
Well,
I love listening to you. How come it seems like It seems like there's so many like twins and triplets. How does that evolve out of this?
It's another thing that's changed dramatically in time. And when we started utilizing this technology, we mistakenly thought that the more embryos we put back, the better the chances of a pregnancy, which may be true in certain situations when the embryos are compromised and not normal. Now we have good ways of identifying single normal embryos, and therefore we only do single embryo transfers today, whereby, and there are some places and some people who probably do multiple transfers. The only time that we will do more than one embryo transfer is in the couple who absolutely want twins. And sometimes that's okay, sometimes it's not. But we will never transfer more than two embryos at a time. And it is also, however, a mechanism that is possibly true with some people whereby an embryo can split. And that's the mechanism to get what's called identical twins.
Right.
And
Wow.
that can happen early in development. And we see it in the early part of a pregnancy. It's a little bit more common in embryos that have been genetically tested because you actually can have a little hole in the membrane of the embryo. So, but it's interesting. You would think that it would happen frequently. It happens in natural society up to 1% of the time. And utilizing this technology, it can sometimes double to 2% of the time, but it won't exceed that.
I imagine some people would actually like that, but that's very interesting. Mark, egg freezing has become very popular for women, 20s and 30s. What should they understand before making that decision?
Well, first of all, it's not for everybody, Garth. It's like every medical procedure. There are indications, there are contraindications, and anybody who's considering utilizing fertility preservation needs to have an evaluation by a specialist that includes an evaluation of their hormones, evaluation of the reproductive system with imaging such as ultrasound, sometimes x-rays, depending upon the individual. But there are certain contraindications, if you will, to egg freezing, which include contraindications to taking what are called gonadotropins. Those are natural releasing factors that come from the pituitary gland. They send signals to the ovaries to get them to make eggs.
Right.
So for egg freezing, more is better. But like everything else, there's a certain area of more that's acceptable and safe. And the problem is that a lot of people utilizing this don't make enough eggs to begin with. So the tendency is to overstimulate the ovaries. That can create a potentially medically dangerous problem called ovarian hyperstimulation that can result in some physical problems, including but not limited to things like peritoneal ascites, pleural effusions, renal failure. So there are a lot of potential problems that can come from the treatment that women need to undergo for egg freezing. And firstly, we have to be careful to screen these people. A lot of them may have blood sugar metabolism problems with different types of diabetes, but it's also very important that the people who are doing the process carefully monitor the patients undergoing the process so that they're not overstimulated.
They need to see you first. They need to
Well,
come
they
see
need
you.
to see somebody does this all the time.
In your opinion, how long does fertility potential realistically last? The frozen fertility potential? Are there limits biologically?
No. If vitrification is utilized, we have people who have used eggs successfully that are more than 10 years old, and the reason why that's true, and it's not more than it's not 20 years is because the technology of vitrification has only been around for about 14 years or so. So, but there's no evidence that keeping the eggs for 20 years would be a problem.
So same thing with men's sperm, cryo.
That's easy, actually, because there's not a lot of water in sperm.
Okay. How has genetic testing, PGT-A, I think, and beyond changed the landscape of embryo selection and successful pregnancy rates?
You know, it's a debatable subject at the moment, in so much as that, in our view, it's one of the critical aspects to IVF because many human embryos, as you know, are not genetically normal. And they can be structurally okay. For example, a commonly known issue with older women called Down syndrome, something called trisomy 21. You know, this is something that
Is it genetic or is it developed because of the age?
well, it's genetic, but it's genetic because of the age. Not always, but there are different kinds of trisomy 21s and Down syndrome, but it's something that embryos will structurally be normal enough to cause pregnancies, but they're just not normal pregnancies. Now, you know, that being said, there are many couples perhaps who would be fine with a trisomy 21 baby, and they're terrific. A lot of the babies are. But, you know, you would then have a choice if you know about it beforehand.
Is there a situation where you say, no way, you shouldn't go forward?
Well, most of the time, Garth, these are situations where the embryos are so abnormal that they will not cause an ongoing pregnancy. Most of the time, they'll cause miscarriages when they're genetically abnormal.
So you see genetics playing a huge role in the future of
Absolutely.
reproductive, and we're getting better and better with all of this.
Yeah, we really are. The accuracy with which we do this testing is exponentially improved over the last couple of decades.
Can you see a disease and take it out so you remove the risk? Or
That's next, we hope.
and people are picking out blue-eyed babies, or how is that? Is that just a
You know, that's kind of a gimmick,
Yeah.
and it's firstly not really ethical to utilize technology for that sort of thing, but it's also not effective, which is probably just as well.
Have you had people request this from you?
Of course.
Yeah.
What's much more common and is effective is when you request gender, because, as you know, one of the chromosomes is the chromosome that indicates gender. And if you do IVF with PGTA, you'll know the gender of your embryo if you want to. And, you know, there are a lot of couples who come specifically for that because other methodologies utilized historically to affect gender selection really aren't very effective. You know, people come in and say, well, I've heard that you could wash sperm and select gender. And that's been touted for many years, but is very ineffective. And the only essentially truly effective way to do that is by identifying the gender of your embryo before you get pregnant. So that's a side
I was
effect.
under the understanding that if a woman has an orgasm during the process, that the environment is acidic and it kills the male sperm off, and so that's why the girls are there. I know that I have 2 girls. I thought that was really what happened, but
Really?
maybe it's not. I'm just kidding. You know, that's kind of a side joke.
I know.
Mark, male factor infertility is often under discussed. What do men need to know about this, and what they typically don't know?
You know, spermatogenesis, production of sperm, takes 90 days. You know, I can't tell you the number of times people will come in and tell me, well, you know, gee, I had too much to drink last night, so I'm not going to try to, you know, produce a child today.
But it happened 90 days
Happened
ago.
90 days ago.
Right.
Whatever you did 90 days ago might affect the sperm that you're producing now. So that's a misunderstanding that most of us actually have.
But you're reproducing sperm every day, no? Or
Yes, you are. And guys, the good news for you is that you produce sperm throughout your life, and it usually is new sperm. Now, it may not be the same kind of sperm that you produced, when you were younger, but it can be very normal. So, it's very possible for a guy that had a problem, 10 years ago to produce new sperm now, 10 years later, and be fine. So, it's not accurate then to have done, or made an assumption that, for example, because you have a 4-year-old at home, that you're fine. Maybe you are, maybe you're not.
Things might have changed.
Things can change.
What lifestyle factors have the biggest impact on fertility for men and women?
A lot of things, Garth. Diet, habits. The nice thing in today's society is not too many people smoke anymore, because smoking is really harmful for both men and women in regard to their fertility. Alcohol consumption, like a lot of things, in moderation it can be okay, but in excess it's clearly not.
Right.
And, the question is, well, what's excess? Well, everybody's different. So for our women, we usually tell them not to consume alcohol when they're trying to conceive.
Right.
And for men, to sort of limit it to perhaps, a glass of wine, if not less than that. So, there is a commonly referred to Mediterranean diet that seems to be good for fertility. Antioxidants are good for both men and women, such as vitamins D, C. It's interesting how many of us are deficient in vitamin D.
Yeah.
Perhaps because we don't sit in the sun anymore, because, people like you tell us not to.
Right,
So,
right.
But
We're connected to the vitamin D industry.
There you go. So, but it's a very clear line between deficiencies in vitamin D and problems producing eggs and sperm. So there's a whole cadre, if you will, of lifestyle changes that can be associated with either compromise fertility or improve fertility. And there are lots of supplements that people take. As you know, this industry, transcends, traditional pharmaceutical industries and the income that people produce for making all these supplements. And, some of them are effective, many of them are not. But antioxidants are probably good. There's something that actually in this country you can get over the counter at any pharmacy called DHEA sulfate, which can be really good for women with what we call low ovarian reserve that have problems making eggs. But you need to take it for a couple of months for it to be effective. So there are lots of things. But, firstly, for a workup, an evaluation, you just have to walk through the door of somebody who is able to do that, and it can be very quick, easy, and not very expensive. It consists for women of an ultrasound and a hormone level, and for men of a sperm analysis and sometimes a hormone level. And you could do that in an hour or less, and have a sense for what your fertility is. And so that's the first thing, because there are a lot of people, particularly professional women, who we see who may be 41 and just came from their acupuncturist and their Pilates session and say, okay, I'm ready to have a baby now. Well, maybe.
Well, so it's important to be in touch with somebody, and I know you do not need more business, but how could somebody get in touch with you if they want to? You're in Beverly Hills. How do they reach you?
It's easy for an email or a telephone. And we developed a electronic record system involving portal systems where we can communicate directly with patients in that manner, get their medical records, give them their test results. There's a telephone that's we can that is utilized for our office, which is, can I give the number or no?
Yeah, give the
Yeah,
number.
310 area 277-2393, and
His
they're
name is spelled Surrey.
correct.
So,
Anyway, there are a lot of people we have that can assist patients get access to care and evaluations. And the first thing to do is just to have an evaluation done.
and it's all very confidential. You've been known for very advanced reproductive surgery techniques. When does surgery become the key to restoring fertility instead of IVF?
It's very different now than it used to be, Garth. It used to be that we would diagnose people with endoscopic procedures, which involve looking into the abdomen through the peritoneal cavity, into the uterus through the cervix. We have imaging that can frequently suffice and circumvent the necessity for anesthetics and procedures. It's a relative question, meaning that if people have significant pathology, such as large tumors, fibroid tumors of the uterus are very common. They can interfere with fertility. If they're removed properly, fertility can frequently be preserved by their removal. Ovarian tumors can affect that. Tubal surgery, interestingly enough, has evolved by almost being eliminated, in so much as that we now know that the lining of the fallopian tubes are what's most relevant in regard to its function, as opposed to just being open or closed. So, you can do these great, interesting, technical procedures to open a fallopian tube, but if the lining's not normal, it's not going to work.
Right.
So that's where the process of in vitro fertilization, or previously known as tubal bypass, comes in, because you're bypassing the function of the fallopian tube, so you don't really need it.
Yeah, that's true. Seems like a no-brainer. Without giving any names, do you have any really challenging cases, like crazy things that happen that would be interesting?
Like everybody in every specialty, there are always interesting things, but just, something that was very moving that kind of comes to mind is there is a devastating disease called Huntington's chorea, which is generally fatal. And a guy who was diagnosed with that, who had one son who was also a carrier and diagnosed with that, came and said, can he have a brother or a sister, and eliminate that, which you can do by genetic testing of an embryo.
Right.
And so we were able to do that, and he now has another son. I unfortunately don't know what happened to him, but he did have another son that was free of
That's
that
a great story.
disease. And,
Yeah.
and that was very moving.
Yeah.
He was a lovely gentleman who I think was a plumber, and it was a very special thing to be able to do.
So what you deal with patients is very emotionally taxing for everybody. How do you, you're so calm, and you're, been doing this so long that everybody feels confident in your care, but how do you kind of navigate that with emotionally stressed out people?
It's a good question, because the process of fertility testing and treatment, as well as the underlying issue of infertility, is a really stressful situation, because most of us human beings are brought up trying to figure out how not to conceive. And when it comes time in our lives when we want to do so, it's sort of taken for granted that, well, this should be easy. And when it's not, it brings up a lot of issues, both creating, marital disharmony and
blame.
This is your fault, it's my fault, or whatever. And
So what do you tell them when they're saying this is your fault, this is my fault, and you step in, you say, look, what's your line?
well, it's nobody's fault, first of all, but we actually internally have people who are licensed psychologists and therapists.
Wow.
And when we first started this, we used to actually insist that anybody undergoing IVF had a consultation with somebody. It doesn't have to be one of ours, but anybody that's qualified before doing so, because the process itself can become stressful sometimes. And like everything else, expectations are key. So when you're, utilizing any kind of technology, and I'm sure in your field you have lots of people that have lots of expectations that may not be realistic. So it's our job as physicians, I think, to counsel patients for creating realistic expectations.
Yeah, that's very important. As technology is advancing, where do you believe the ethical boundaries should be placed in reproductive medicine?
Well, you mentioned something earlier that would be utilizing this stuff for phenotypes such as, blonde hair, blue eyes, or whatever. That's almost abusive, if you will, when you consider the utilization of this kind of technology to prevent diseases, to eliminate certain cancers and things of that nature, and utilizing it for, one's own pleasure is a little bit ethically questionable.
And there's some people that they don't care. They want to do it.
Of course.
Yeah, of course. How close are we to the artificial gametes, lab-grown eggs, sperm, even external womb technology? That's exciting and concerning at the same time.
Yeah. And, it's interesting that we're not as far away as people think. I just was in a conference in New York with some people from Europe who are starting to grow gametes, sperm and eggs from skin cells. So, it's not too far away.
With the robots, it's coming. After helping so many families, what gives you the greatest sense of fulfillment in your work, and what legacy do you want to leave behind?
I think it's, first of all, very fulfilling to see positive results. And, for us, it's children. And when we see the byproducts of our work walking around, or even getting holiday pictures this time of year, it's very rewarding. In regard to a legacy, I think that's the legacy is to be able to help people have families.
With rising demand for IVF and egg freezing, how do you see the economics and accessibility of fertility care evolving?
The economics are evolving rapidly with politics and things that direct insurance companies, because, for example, now in California, as has been the case in some states for years, there are going to be mandates for fertility coverage. Now, the problem with mandates, as you might imagine, is that it's limited to a select group of people. So, for example, in Massachusetts, it's mandated coverage, but not if you're a woman who's 42. That's
where do
you're
you draw the
excluded
line?
for that.
Yeah.
Well, you had to draw the line somewhere.
Yeah.
So
arbitrary.
It is, but it's usually somewhere around, and there are no cutoffs with human fertility, but age is relevantly, is important.
It's important. It's important because you're going to get in some risk areas.
Yeah.
How many people work in your office? Are you the only doctor there?
In my office, there are 6 MD physicians, and we have offices also in Pasadena and Santa Barbara, so 2 of them are in what we call satellite offices there.
Right.
We actually have a separate lab in the office in Santa Barbara that I go to once a month or so to do some cases. And with IVF, Garth, it's interesting that with the medications that we use now, we can kind of plan them out. In other words, there are weeks in the month that we cycle people and other weeks we don't.
Right.
So there are some MDs. We perform the IVF procedures for 2 of the major medical centers in the area and also train the fellows. And so there are another few physicians that work full-time at the medical centers who utilize our facilities.
You must have a lot of people that are coming up to you like, thank you for letting me be born and come into this world. I don't know if you've had anything like that, but that's just got to be so gratifying to be able to see that you've went over this hurdle with the family.
It really is.
How many kids do you think are out there because of you?
It's a tricky question because it implies just me personally or
no.
my
You're part
center.
of you're part of the process.
Yeah.
It takes the male, the female, the doctor, the staff,
Yeah.
But I'm sure there's just a lot of them out there, and I won't make you put a number on there, but I'm sure it's a big number.
Going to be thousands, probably.
Yeah, I'm sure it is. What do you do for fun?
Good question, because I have such a bad golf game. I think it's supposed to be fun, but there was a guy who's a comedian coming up across from me on another fairway, cursing and throwing his clubs and saying, "I can't believe I do this for fun."
Oh, yeah.
And
Well, at least you're getting vitamin D out there.
yeah.
I'm the same with golf. I don't have the patience. I can't spend 4 hours outside doing that. And I'd be thinking I need to be doing something else more productive. And I'm such a competitive person and such a OCD that if I can't do it well, I just don't want to do it at all.
Yep. It's difficult.
Anyway. Well, we're here with Dr. Mark Surrey. We've had a great conversation with him. He's a fertility expert, the best, I think, in the world, in my opinion. And we've learned a lot, and it's going to be really great for the viewers. If you missed this show on the radio, you can also watch the Cutting Edge Instagram at Garth Fisher, MD, The Cutting Edge. And I want to thank KCBS, Odyssey, our sponsors, Cal and Mike, and our producers, the Cutting Edge team, and, of course, you, our listeners, who are the most important. This is Dr. Garth Fisher on The Cutting Edge. We'll see you again next week. Thank you so much for coming.
My pleasure. Thank you, Garth.
Thank you
Good
very
to
much.
see you,
Good to
as
see
always.
you.